New guideline clarifies surgical margins in treating breast cancer. For patients with ductal carcinoma in situ, DCIS, who are undergoing breast-conserving surgery with whole breast irradiation, WBRT, a 2 mm margin should be the standard, according to a new guideline jointly released by the American Society for Clinical Oncology, ASCO, the American Society for Radiation Oncology, ASTRO, and the Society of Surgical Oncology, SSO. The guideline, designed to provide clarity regarding the optimal negative margin width for DCIS, a disease that accounts for approximately 20% of breast cancer cases, was published in Annals of Surgical Oncology, Practical Radiation Oncology and the Journal of Clinical Oncology. It was also designed to limit patients from undergoing unnecessary surgery while simultaneously reducing healthcare costs. For negative margin widths, the guideline recommendations state that margins of at least 2 mm are associated with a reduced risk of ipsilateral breast tumor recurrence, IBTR. Evidence does not support the routine practice of obtaining negative margin widths wider than 2 mm, the panelists stated in the guideline. The use of a 2 mm margin as the standard for an adequate margin in CIS treated with whole breast radiation therapy is associated with low rates of recurrence of cancer in the breast and has the potential to decrease re-excision rates, improve cosmetic outcome and decrease healthcare costs, the organizations wrote in the joint statement. Clinical judgment should be used in determining the need for further surgery in patients with negative margins less than 2 mm. Margins more widely clear than 2 mm do not further reduce the rates of recurrence of cancer in the breast and their routine use is not supported by evidence. Additionally, the recommendations state that a positive margin, defined as Inc on CIS, is associated with a significant increase in IBTR that is not nullified through WBRT. Treatment with excision alone, regardless of margin width, was found to be associated with substantially higher rates of IBTR versus treatment with excision and WBRT, even in predefined low-risk patients, the panel found. Optimal margin width for treatment with excision alone is unknown, but should be at least 2 mm. Additional evidence suggests lower rates of IBTR may be associated with margin widths wider than 2 mm. Endocrine therapy, however, was found to have reduced IBTR rates, but no evidence exists of an association between endocrine therapy and negative margin width. The guideline initiative was composed of a panel of experts from each of the organizations, and included clinicians, researchers and patient advocates. The panel examined the relationship between margin width and disease recurrence in approximately 30 studies. In one such meta-analysis, researchers conducted a comparison of specific margin width thresholds, 2, 3 or 5 and 10 mm, relative to negative margins defined as wider than 0 or 1 in 7,883 patients with a median follow-up of 6.5 years. Here, the predicted 10-year IBTR probability for 2 mm negative margins was 10.1% compared with 8.5% for 3 or 5 mm, and 11.7% for 10 mm margins. An important finding from the review of the published literature performed to provide evidence for this guideline is that margin widths greater than 2 mm, approximately 1/8 of an inch, do not reduce the risk of cancer recurring in the breast in women with CIS who are treated with lumpectomy and whole breast radiation therapy. Monica Morrow, past president of SSO, panel co-chair, and chief of breast service in the Department of Surgery at Memorial Sloan Kettering Cancer Center, said in a statement. See more.